I want to thank everybody for joining us. This is the AAHPO COVID Town Hall. We're coming up on almost a year since we began this program. And I want to thank all of our listeners, all of our guest speakers, as well as our panelists. Dr. Kojaglon, you can't join us this evening, but we're so lucky to have Dr. John Bilazikian and Dr. Kim Akeemian. Thank you again for being with us. This was a very interesting week. We've had some medical breakthroughs, which we'll discuss in a minute, but Twitter has joined Facebook now in labeling COVID-19 misinformation, and they have a 5-strike policy and you're out. So if you make any statements that are patently false and misinformation about the virus, if you make misstatements about the efficacy of treatments and preventative measures, or misinformation about restrictions and exemptions in health advisories, or misrepresent the death rate or the prevalence rate, or have any misleading information if you portray yourself as a healthcare provider and you're not, or miscast yourself as a different type of healthcare provider. Any of these will qualify as misinformation and as a strike. And again, 5 strikes and you're out. So I thought that was interesting that they're actually doing this. So I'm going to introduce Dr. Kim Akeemian. We all know her as Kim. She's totally awesome, a real workhorse in addition to her day job, all the extracurricular events she's doing to help Armenia. She's an assistant professor of nutrition at the Pediatric Institute of Human Nutrition, associate director of education for the program for global and population health at the Vagelos College of Physicians and Surgeons. She's also a standout board member of the Armenian American Health Professionals Organization.
In our field of public health, what we're interested in 2 things: the actual availability of the vaccines, and the second is the actual vaccination with those vaccines. So this is the first, which is great that we reached today, as you mentioned, 2 million doses a day now of supply, and that will only increase with the new Johnson & Johnson vaccine as an option. In terms of public health messaging, for an audience that might look at this video another time, I will just repeat. The message is that you take the vaccine that's offered you, that all vaccines are good. They're all safe and effective at protecting you from severe cases and hospitalization and death. And there is a lot of buzz now about people who are questioning whether they should, wait to get a different type of vaccine, or, whether the one shot is better, whether the platforms are different. And I think that's really tough for public health messaging, particularly for people who are hesitant. And that is another topic for another day, but there is still quite a bit of entrenched vaccine reluctance and outright, anti-vaccine misinformation and disinformation in some communities. This is a map of the world in terms of total doses administered per 100 people. Essentially, about 20 countries in the world own about 80% of the vaccine supply, and many, many countries in the world have not received any vaccine supply. And that includes, you can't see it here, but that includes Armenia as well. Armenia and Georgia have not received any vaccine at all. And I believe Azerbaijan has received a little bit of the vaccine from Russia. So that is sort of the global picture about vaccine distribution, which we, in general are very excited about. As for Armenia, I will share with you that Tsolin and I are on an advisory council with a few other people we're in a vaccine advisory council for the Ministry of Health of Armenia. And we've been just privileged to have a lot of discussions with the stakeholders there. It's really tricky for the lower and middle income countries. Armenia has, they're part of the World Health Organization COVAX Alliance. They have made a deposit into that alliance to receive at least enough vaccine for 10% of their population. They originally signed on for AstraZeneca when they had to make that choice of what they wanted in the alliance, and which we supported, and that was before the war. And now AstraZeneca is quite behind in their own production and distribution. So what Armenia thought they would get in February has been now delayed. They thought they would receive 600,000 doses in mid-February. that has been reduced to 150,000 doses, which they thought they would get by mid-March. And now they've been promised that 150,000 doses by the end of May. And so unfortunately, Armenia is not going to be in a position to be able to start their vaccines.
Thank you so much. It now really is a great pleasure to introduce a friend from way back in medical school. We first met in Philadelphia at a budding group of Armenian physicians in Philadelphia. We were part of that inaugural group. The group later faded, and now Delaware Valley Armenian Professionals Organization is established, and Karl is its leader. So great job, Karl. What a circle we've both been through. Karl is really a wonderful person. He's also married to a Nigerian. That makes him very special. He is a professor of not only psychiatry, but also of neurology and medicine. He is the director of the Jefferson Sleep Disorder Center. He's a program director, fellowship in sleep medicine. He's a clinician, a researcher, an educator, and a physician leader. He's been rated top doctor by Philadelphia Magazine, where he practices in Philadelphia, Castle Connolly, U.S. News and World Report. I don't know when you find time to write, but in between all of your activities and DFARA meetings, you've written 214 academic articles, a good number of them peer-reviewed, 121 book chapters, 8 books, 63 abstracts, and have done 236 presentations. I guess tonight you're 237. You have received over 45 grants. So really, it's with great pride that we introduce Dr. Doghramji this evening. Thank you so much for joining us.
Well, thank you, Larry, for that wonderful introduction. So I wanted to today really talk a bit more on the practical level about some of the issues that are confronting our patients who in this era of COVID, and what we're seeing and what we might be able to do to advise them on sleep issues. And of course, some of this advice applies to us as well. The issues that are really confronting our patients that have impact on sleep are on this slide. So people are spending more time homebound. Their lives are more sedentary. There's less physical activity, less exposure to environmental light during the day. Light has a strong influence on sleep. They're using their personal space for work. You know, their works and balance between work and non-work, the space-wise, geographically, has diminished, is merging. The socially becoming isolated, and worry and emotional upheaval about economics, personal and family illness, exposure to difficult work situations, and of course, fear of exposure to the coronavirus. And many of our patients have lost people. I've had a number of patients who've actually lost relatives and loved ones to COVID. Sleep problems which are arising as a result of this, and I'll focus only on the sleep issues. It's taking people longer time to fall asleep. They wake up repeatedly after falling asleep. So they go to bed and they just begin to wake up a lot. Sleep, or they sleep through the night, but they wake up and they say, you know, it's been an unrefreshing night. I just feel like I haven't gotten enough out of my sleep. Or they sleep late into the day. Their mind is overly active when they go to bed. Dreams have become disturbing. Nightmares are becoming more and more problematic. And they become fatigued. Mood is low. They become moody. The attention decreases. Memory problems arise. I do a lot of telemedicine visits, and I see this all the time. I'm talking to patients, and you can see them. They're sort of sitting around during the day in their bed with a dark room. You know, there's a sense of gloominess in their surroundings. So these are some of the issues that our patients are confronting from a sleep standpoint. Now, let me talk a little bit about the practical ways in which I advise patients to overcome some of these areas. So I'm not going to go over this entire slide because that's my presentation, essentially. I'll pick each of these points one by one. But one of the most important things is to actually set aside a worry time. You know, we spend a lot of time trying to avoid worrying about things. Paradoxically, spending time worrying about something is actually more productive and leaves us a bit less anxious. I tell my patients, you know, you're spending a lot of time trying to not worry about the things that are bothering you. I'd like you to spend half an hour, only half an hour, before dinner, after dinner, just sitting down and doing nothing, but thinking about those things that are very troublesome to you and worry about and do a worry time, either with somebody or by yourself. Interestingly, many patients come up with a sense of being able to understand these things a bit better. Some of the behavioral things, doing something relaxing before bedtime. You know, many of us do all sorts of things and we come to bed and we're all of a sudden stimulated and can't fall asleep. So, you know, meditation is a very good thing. Or things that are pleasurable, but not overly exciting, such as spending time with a favorite dog or whatever. Warm baths. Some people prefer a warm bath. As many of you know, warm baths have a soothing effect. And once people fall asleep, if they cannot fall asleep quickly, the advice I give them is not to stay in bed, but to get up out of bed after 30 minutes or so and to do something different in a different room. This idea of staying in bed and trying harder to fall asleep often has a negative impact, actually makes people become more and more phobic about sleeping and become more obsessed with the idea of not falling asleep. So getting up out of bed, spending time out of bed when coming back to bed when people feel sleepy is a very helpful technique. Not watching the clock. I mean, many people are so focused on the time that they watch the clock and it makes them feel more and more anxious. So turning that clock around and leaving the world go, so to speak. Many of us see this, that patients are sort of merging workspaces with living spaces. And I advise patients, especially those who live in small apartments or living in small spaces, to buy these curtains or separation walls, these fake walls, and make a workspace very separate from the place that they live in and sleep and have fun in. The psychological separation can be really important for many people to sleep better. And use the bed for sleep and intimacy, of course, but not for anything else. You know, people, again, are taking their computers to bed, their laptops to bed, and it's just the psychological association the mind makes is that the bed is a place to be avoided. The bed is a place that is aversive, is anxiety provoking. Light has a strong effect on our sleep and wakefulness. You know, we've evolved as creatures of a sun and light and darkness cycle. And that cycle is still within us, controlled by many pacemakers, which are not only within the brain, but also within the rest of the body. So dimming lights in the evening is very helpful for many patients. And those of us who cannot, patients who cannot produce enough dimness, if you will, because they're sleeping during the day, shift workers, for example, can purchase these very nice shaded curtains, which keep the light from coming in. But for the average patient, dimming the light is helpful. You know, many people do these iPhones and PDAs, and these actually have a lot of blue light. Interestingly, blue light is one of the most offensive spectra of light that modulates melatonin levels. And this modulation can be in the wrong direction. People also look at computers and so on. These are things that can make matters worse. There are many eyeglasses which filter out blue light. They're commercially available. Many of them are better than others. And wearing these blue light filtering glasses for an hour or two prior to bedtime can be very helpful in mitigating the effects of these smartphones and computers. In contrast, during the day, a very brightly lit environment is helpful. You know, morning light has the effect of synchronizing our biological rhythms. Many of you remember the suprachiasmatic nucleus and the role of light in producing melatonin. So light has an inhibitory effect on melatonin, and darkness has a permissive effect. And by inhibiting melatonin in the morning, this actually produces alertness throughout the rest of the body and gets into sync the rest of the body physiologic mechanisms, the GI tract, the liver, the intestines, the heart, the lungs. All of these begin to sort of wake up and participate in this wakefulness mode, which is so important in producing a sense of wellness throughout the day. Interestingly, this light and darkness alteration is also used by many sports teams. When they travel west or east, they begin to simulate their environment through light and darkness, and it's been shown to increase scores on the NBA, for example, by simply manipulating light-dark cycles. The things that are also common sense, avoiding caffeine. You know, some of us have a mutation in the genetics that are responsible for degrading caffeine in the liver, and they are very sensitive to caffeine. So consuming caffeine even after lunchtime may be problematic for some people. So no caffeine after morning hours, certainly not after lunchtime, would be a good idea. And of course, avoiding some of the things that we know are aversive for health and not eating within 4 hours of bedtime. The regularity of bedtimes is also critical. You know, we are creatures of regularity. And if we wake up later in the morning, that seems to drag to a later time, the evening sleep time. So the later waking in the morning produces later sleep time at night. And many of these COVID, many of us, many of our patients who are, working from home, sort of are dragging their wake times later and later, producing greater difficulty falling asleep in the beginning of the night as the days go along. So regularity in waking up in the morning and light exposure in the morning is really important. And finally, a good exercise routine. You know, people are indoors, they're not getting out too much. And I advise people to buy these exercise cycles if they're available. You know, it's hard to get them nowadays, they're all sold out. But some form of regular exercise, especially not within 4 hours of bedtime, could be very helpful. Room temperatures, a little on the cooler side, seems to be helpful for sleep, and as opposed to warmer surroundings. Finally, there are many of these CBT or cognitive behavioral therapy online programs that patients can go to. The first one on this slide is a free one. The second and third have a modest fee associated with them. And these programs can guide patients through these behavioral techniques and help them in reducing stress. Jefferson has a number of stress reduction techniques for their employees, and I'm sure many institutions do as well. These are free, and I strongly recommend them. And we also have at Jeff and many other places cognitive behavioral therapy, or sitting down with a trained therapist who can work on not only these behavioral changes, but also on some of the psychological aspects which are so problematic, including reduction of tension through biofeedback and other relaxation techniques. Many of our patients, cannot do well with these techniques, and we use hypnotics, sleeping pills, as well as other pharmacologic agents, depending on the problem, antidepressants, and so on. And I think the news is a good one. In many of us, many years ago, were trained to think, sleeping pills are bad, they're addictive, they produce problems. And in fact, the older ones probably did. But the newer array of medications that are emerging in the area of sleep are really quite positive. The melatonin receptor agonists, for example, like Ramelteon, or histamine receptor antagonists. The histamine is an waking neurotransmitter system, and antagonizing that system through through histamine H1 blockers seems to be helpful for sleep. And finally, orexin receptor antagonists. These are agents which block orexin neurotransmission, which seems to be important in wakefulness and arousal and many other things like satiety and so on. By blocking that, are producing sleep in a safer way, we think, than some of the older benzodiazepine receptor agonists. Those of you who are interested in learning more about this area, and this is my plug, if you will, are welcome to join us in the 7th Annual Sleep Medicine Symposium at Jefferson. This is coming up on Friday, March 29th. There is a slight matriculation fee, but it's virtual, it's online, it's an all-day symposium, and it'll be addressing many of the topics I addressed, as well as things like hypersomnia, headache and sleep, COVID-19 effects on sleep. Dr. Charles Marin, who's an expert in the area, will be speaking about that. We'll be talking about the narcolepsy as well as sleep apnea, new areas of treatment for sleep apnea, including upper airway stimulation therapy, and so on and so forth. So those of you interested in knowing more about sleep at greater depth, you may want to register for this symposium. Well, I want to thank all of you for your attention. Hopefully I didn't put anybody to sleep. I'll be more than happy to answer some questions.
We received a question. I'm a senior. I've suffered from sleep deprivation, intermittent sleep for a while, especially since March 2020. The problem is I can go to sleep, but after 2 to 3 hours, I wake up and have difficulty going back to sleep. So I don't sleep more than 3 to 4 hours at any one stretch, and my sleep is mostly light. I go back to sleep out of exhaustion. I also remember and record my dreams daily. I function well during the day and I'm not sleepy. I've tried to use mint tea, valerian, melatonin, Tylenol PM. None seem to help me get that 6 to 7 hour restful full night's sleep. What are your thoughts?
Yeah, you know, it's difficult, of course, Larry, as you know, to do a diagnosis based on one symptom alone. And the job I would have if I were having a patient like this would be to try to dig deeper to find out what are the factors that are causing this, as opposed to jump to therapeutics. You know, many years ago, we used to jump to sleeping pills with these sorts of complaints, but now we know better. We know that the job is to go down to identify the specific things that are causing this. And the causes could be many. On an emotional plane, it could be a depressive disorder. On another plane, there could be substances, for example, contributing to poor sleep at night, such as caffeine, diet, and so on. On a medical plane, there could be something along the lines of a breathing disturbance during sleep, like sleep apnea. On a neurologic plane, it could be narcolepsy. Narcolepsy produces a lot of disruptions in sleep during the night. So my job would be to identify which of those, if others, the problem is, and to zero in and treat that. I would say to the person who's voicing this question, if you are to, maybe you should try some of the common self-help techniques that we talked about in today's lecture. And if those are not helpful, then you should seek out maybe some professional help. There are many physicians, sleep medicine docs in the area. They're all over the place. I'd be more than happy to talk to you by telephone and dig deeper and find out what might be causing this and help you solve that problem.
We do have another question in the chat, but you did mention something earlier, which struck a chord with me. William Carlos Williams was a famous physician poet, and he said he used to love to make house calls because he could eavesdrop on people's souls. You mentioned that when you did this telehealth call, you gained an insight that you may otherwise not have gained. What is the role of telehealth in your practice, given your experiences that you've had through this pandemic?
Yeah, I mean, I'm sure many of us share in this, Larry, that telemedicine and telehealth has been so helpful. Number one, in just continuing just promoting continuity of care in patients, many of whom cannot come in to the office. But the other number of interesting benefits for me have been that I've been able to share with patients sort of a glimpse of their homes and what they do in their personal lives. You know, it's one thing to see your patient in the office. It's another thing to be able to see your patient and their surroundings, their background, their homes. I was speaking to a patient today, a man, an elderly gentleman, and he was telling me about his difficulty, and it turns out he has congestive heart failure and has a severe sleep difficulty induced by central sleep apnea, which is very common in patients with CHF. And you know, I was talking to him, and then he couldn't quite understand the question. And his wife heard me, came in and sat next to me, and next to him rather, and started elaborating on the conversation. It gave me a lot of great answers. And then she took the camera and sort of wove it around and showed me this man's room. I mean, he lives in she showed me how he lives and how secluded he is, because how isolated he is because of the congestive heart failure. He can't walk around very much. He's stuck in one place. And he's also developed a secondary depression, which is now being treated, hopefully being treated by somebody else. So it really gives you a glimpse of the patients and their homes and and it invites us into their lives in a way that I really haven't been able to get by simply seeing patients in the office. So hopefully that answers that question.
No, it's in my experience also. I know I had a patient complaining about dry eyes, and we did a telehealth exam, and she was sitting in a very small room, staring at her computer with a fan over her head, blowing in her face. So it really shed a lot of light onto the issue at hand. You got a compliment, great practical approaches. Congratulations. Thank you very much. What contributes to waking up suddenly from sleep? Not due to dreams, etc. It was mentioned in the talk, but not sure if this is something new due to COVID pandemic. Can you elaborate on that?
Sure. Well, there are things called sleep starts, which are these sudden sort of awakenings, which occur especially when we're falling asleep. These are pretty common human experiences, and they seem to happen at greater frequency in people who are sleep deprived or not getting enough sleep. And what we think happens is that when we go to bed, instead of this gradual transition that the body seems to like from a shallower to a deeper stage of sleep, there's sort of a much more rapid transition. And there's a resetting, if you will, where the body sort of says, wake up and let's do that over again in a better way. They're called sleep starts. A second common cause of these sort of sudden awakenings during sleep is anxiety. Some people have anxiety during the night, during sleep, anxiety attacks to be precise. When they wake up, some people also have a sense of shortness of breath or breathlessness, kind of a sense of sometimes tachycardia, sweating. All of these are panic attacks which occur during sleep. Interestingly, 25% of panic attacks occur only during sleep and not during the day. So that's a second sort of common cause. Third cause of suddenly awaking is gastroesophageal reflux, Gerd. So when acid goes into the esophagus, the only way the esophagus can clear acid in a sleep state, the mucociliary action does not work well when we're asleep. So the only way the esophagus can clear acid is to promote a wakefulness reflex. And that's typically a very sudden wakefulness reflex. So those are the three most common things that can cause sudden awakenings during sleep.
That's very interesting. Thank you for presenting it that way. You mentioned trying to control the light to set the mood, that you don't watch a pounding movie, do heavy exercise. What are your thoughts about listening to relaxing music and sounds with earbuds to go to sleep? Is that helpful or is it disruptive?
I think it's a great idea, Larry. Basically, anything that helps. Some people, listen to music. Others like to listen to news radios. Others like to, listen to podcasts that are boring. We actually have a study going on at Jefferson now in the stroke unit, believe it or not, with patients who are emerging from stroke or from brain insults. And we're trying to see whether or not exposing them to music will help them emerge from this stroke a bit more rapidly and be able to restore mental functioning a bit more rapidly. Because we know that stimulating people in a very sort of in a mild way, gentle way, can be helpful to the brain and also can help reset circadian rhythms. So music, voices that are not stimulating but are sort of help us sort of capture that sleep mantra, if you will, may be very helpful for some people. I think the thing to avoid, if possible, are light emitting devices, cell phones and so on, because those are disruptive and we can't control them well unless we wear those glasses. But sounds that are soothing in nature. Many people buy these relaxing audio tapes of beaches or whale sounds, the forest. Those are also sometimes very helpful.
I want to thank you again, and Dr. Doghramji, thank you so much. And have a good evening, be safe, and we'll see you soon.